Christian Desai. I'm a periodontist here at CTP. I was born and raised in Scranton, Pennsylvania before the office made that area very well known. My dad is a general dentist. He's been there since the 70s or late 80s, and we grew up in what was like a small town. He did general dentistry for years. He still continues to do it, and that's where I got my interest in the dentistry. He had his own little lab, so I'd go kind of work in the lab with him, sometimes just go visit him and see how the interactions with patients were. And it was a time before technology and videos and cell phones, and it was a lot more personable, and I really liked that. And I always had an interest in medicine, was kind of on the fence, like, do I want to go into dentistry? Do I want to go into medicine? And in high school, I kind of made this decision to go into dentistry straight, with a combined program of applying right from high school into dental school and then doing some cross courses in undergrad. So I went to Muhlenberg College in Allentown, Pennsylvania for 3 years, and then went right to the University of Pennsylvania in Philadelphia afterwards. Finished dental school there, and then applied and went straight into residency at Eastman, or now it's called the Eastman Institute of Oral Health, but at that time it was Eastman Dental in Rochester, New York, and it was associated with the University of Rochester, which was nice because they have a hospital system there, Strong Memorial, and so we were allowed to rotate through. So we got a semi-hospital experience and a semi-private practice type of experience there. Did my periodontal training there, got my periodontal certificate, met my wife while I was in residency, and she's a physician, and she was finishing up some of her training, and we both got married right after residency, had 1 month to figure it all out, and then moved to Philadelphia, where I worked for about 4 years, and while she was finishing up all of her training. And then we made the decision to move to Austin at that time. Her family's from Texas, and it was, prior to Austin being what Austin is now. And we really liked the people, the atmosphere, the outdoors, and came here. And I worked for a practice for a little bit while I was transitioning into trying to find what I wanted to do. And I really wanted to open my own office. And as I was looking, I was talking to some of the dental reps, and one of them mentioned, like, hey, why don't you, your personality seems like you get along well with a doctor I know, Dr. Kalia, why don't you guys meet? So I went and met John at his office in Pflugerville at the time.
That was when we had 2 offices.
Yeah, and that was when John had 2 offices. Pflugerville was the newest. It was kind of a...
What year was that?
I want to say it was 2014. And
10 years ago?
Yeah, about 10 years ago. And then we hit it off right away. We had similar interests and kind of similar thoughts, and the families met, and we just kind of were like, all right, let's figure out, John was like, I want to work with you. I'm not sure how we're going to figure this out, but let's make it work. So
yeah,
kind of came into Pflugerville with, at that time, I think you were only there 1 day a week.
Right.
And it was very much a new satellite office, and Pflugerville was not very built up at the time. It was still very much a small town. And so we started, and I started there kind of just full steam ahead, and we've been there ever since, and then we slowly just kind of grew from there.
So, well, my name is Jonathan Kalia. I go by John, and I have a very similar story, probably to both these guys. I went to dental school in Kansas City, where I grew up, and then I specialized in periodontics at Baylor in Dallas, and so kind of the same thing, no breaks, just straight from high school all the way through.
Yeah.
You know what I mean?
And then right after Baylor,
Yeah.
you went straight to San Antonio, right?
Yeah, my first job was in San Antonio, and then after about 3 years, my wife and I, Ned, relocated to the Austin area and opened Georgetown, and then Pflugerville a few years later, and then Christian came on board, and then here we are.
Where did you and Netta meet? Is it in Dallas or was it in KC?
Oh no, we met in South Padre.
Oh, South Padre.
Yeah, at a bar in the
Nice.
parking lot.
But she was in college at the time? Or you were in college?
You were
Yeah, I was in my first year of dental school.
Dental school.
You know that first year you get the summer off.
Yeah.
Uh-huh.
The only summer off.
The
The
other
only
summer
summer
off.
you get it for the rest
Well,
of
I
your
didn't get my
life.
summer off after
Oh, you didn't?
in dental school, no.
Yeah,
I worked with Eric and
Oh, did you
and
really?
I was over there.
Oh, okay.
Yeah, so
Yeah, so that summer off, I took like a last minute trip to
South Padre.
South Padre with a buddy. We drove there, and that's where I met my wife.
that's amazing.
Yeah, it's pretty romantic, right?
My name is Sham Shah. I'm originally from a small town in western Massachusetts called Lenox. I lived in Massachusetts for the first 28 years of my life. I did my college there and dental school there at Boston University. I specialized my major in college was computer science. I was always into computers growing up, and so technology for me is very important. I would be the one building and fixing computers, and I was kind of the IT guy for all my friends and all my family. And then I went to college, and I just always wanted to do something with my hands, but I also wanted to be some kind of doctor or surgeon, and that's kind of what brought me to becoming a dentist and eventually to perio. Perio to me is very special. I love the medical aspect of it and the surgical aspect of it. It's fun learning about new technology every day. We incorporate all of that I learned at my residency at New York University. That was a 3-year program that I did, and it was a very surgical-based program. We were in Manhattan, a lot of patients coming from far away to come see us, and it was a really good program. After I graduated from NYU, moved back to Massachusetts, and I worked under a top implant specialist over there for a couple of years, and then my wife and I decided that we wanted to get kind of a change of scenery, get out of the snow and out of the cold and get into sunny Texas. And her sister was living here in Austin at the time, and so it was just kind of the perfect switch to come here and move here. And then we're lucky that that implant specialist in Massachusetts is good friends with Rishan.
Yeah.
And so he called Rishan and said, "Hey, do you have a spot for a new doctor?" And he said, "Yeah, let's see him."
Yeah, it was a small world.
How did that
Yeah.
work out?
He,
What was the
he
conversation?
randomly was like, "Hey, my associate, who I really like," and we know he was lying, but was like, he's moving to Texas, and he's looking. I think he mentioned, this might not be completely accurate, but he said like he's kind of looking at like Houston, Austin, trying to figure out where to go. And I really like him, and if you have a place, like, just meet him and see what you think. And I was like, actually, we're looking for somebody else, because at that time, John and I were still rotating through a lot of our offices, and it was just taxing, like, oh, I'm at this office, then this office, then this office. Like, it was just becoming a lot for us to manage. And so then you came in kind of at the right time. And you fit the kind of the vibe that John and I were going for, which is not this like stuffy, I'm a, periodontist type of thing, but more like, hey, we want to do something, we want to build something for the community and to grow with. But, we're kind of like, John and I are like family. Like, we do a lot of stuff together, we go on trips together. So we want somebody that we can continue that aspect with, and
Yeah, we need someone to watch the offices when we're gone.
yeah, that too.
Someone we trust.
So
Well, I appreciate that you trust me
Yeah.
to do it.
Yeah.
technically, we hired you just because of your IT skills, and
And to cover us when we go on vacation.
yeah, but
That's all right. It's
it
working
turned
out
out
for
you
me.
were a great periodontist, so that worked out for us. Did you have any family members that were dentists? I always feel like
actually I
dentists
didn't.
have somebody that they
Not
know.
me.
I was the
No?
first doctor
Not
in my
me.
family, any kind of doctor.
Really?
Yeah.
Yeah.
My sister's a PA, so that's the closest to it, but no one else
No
at
one
that
was
time. Just I always had an interest from when I was little, just from watching TV shows and whatever. I thought that was so cool, and always into science and medicine and stuff like that. So that's kind of what brought me to it.
Yeah, because patients are always asking me like, how'd you get into dentistry? And for me, it's kind of like, oh, my dad's a dentist, so I was like ingrained with it. Although my brother and sister hated the idea of blood in teeth and anything like that.
Actually, now that I think about it, when I was 15 or 16 years old, I had a hockey accident. I was playing hockey at my friend's house, and I got hit in the face with a hockey stick. The follow through of a shot, and I was wearing a mouth guard.
Yeah.
Why would I? I'm 15
Yeah,
years
you're a
old.
kid.
I don't
Yeah.
care. I got hit in the face and knocked my 2 front teeth pretty much clean broken, and the teeth flew out and fell onto the ice. Obviously, it's ice, so you can't see anything. But then, where everyone's searching for my teeth, and it's just the weirdest thing. But then someone finds my teeth. Well, I found it, and then my friend's mom is there. She puts it in milk. We go to my dentist, and then he glues it back on.
That's, I always think it's funny because like when you think about it, it's like, why would you get into teeth, right? Like of all like the professions you can choose, like how do you get into teeth? And I never really thought about it because like growing up, my dad, that was just like the norm, right? Your dad's a dentist. You're like, all right, yeah.
You see it all the time.
Well, and you see the struggle too,
Right.
and you're kind of like,
Right.
do I want to do that? But then I was always interested in medicine and dentistry or medicine, so I was like, well, I also see my aunt and uncle are constantly on call. I don't know if I want to do that either. But then the other flip side, it's always like either trauma or somebody had like an awesome orthodontist, and they were just like, oh, I had a great experience, and that's it. But otherwise, it's like, of all things to pick, teeth.
So CTP, Central Texas Periodontics, was a result of the original office, which was called Georgetown Periodontics. And then when we did the satellite, we just simply called that Pflugerville Periodontics. And then we figured out it would be a lot easier just for letterhead purposes to have one name, and Central Texas sounded good and no one else had that name. So CTP.
And at that time too, I feel like, Austin was still very much, Pflugerville and Georgetown weren't as close as they seem now, right? They very much seem like two different entities of space.
They used
Yeah.
to.
They used to.
They seem
Yeah.
more spread out.
Yeah.
Like if you were gonna like go to Georgetown, it was a big
It was a big
outing.
deal.
It's just like,
Yeah.
but everything's kind of closed because it's just like all the highways are developed completely. There's no empty spots anymore.
Yeah.
But
Because I remember when I started at Pflugerville, like the thought of a Pflugerville patient going up to Georgetown was like, I don't know if I want to go up that far, and now it just seems so like, oh yeah, like,
We'll go there. Every
Yeah.
yeah,
yeah, exactly. Because I have patients that live in Pflugerville and they get to Georgetown, and maybe they just probably like me so much, but they don't want to go back to Pflugerville.
yeah. I mean,
They'll
you've had that
drive.
relationship for years.
Yeah. So, but yeah,
Were the highways like 45 and 130 not there?
They were
yet?
They
there.
were there, but they weren't just.
they just opened. When
Yeah,
when
they were
moved here.
relatively new at
Yeah.
that time. I mean, and it was a new concept to take a toll road, because back then it was a lot more, grew up in Austin, live in Pflugerville, like you were living outside of the city.
Right.
It didn't feel like, oh, you were a part of Austin or a suburb of Austin. I mean, Round Rock was even such a new concept at that time. Like the idea of this big area and Round Rock's growing, it was more like, wow, this is a new city outside of Austin. But yeah, it was an interesting time when we first started. The idea of just having two periodontal offices under one name was even like, wow, you've got a satellite, you have two offices. And then John and I, we're talking, we're always got ideas. We're like, well, I really want to be in this place too, because I feel like that place is gonna grow and nobody's there.
Yeah.
And so we started talking a little bit about Leander. And at that point, there was nothing out there. I mean, there weren't even any medical office complexes, or there were very few. And we didn't really like it, so we started looking at land. And we found this place that was going to be developed into a medical office condo complex. We're like, all right, this could be a nice spot. It's like far enough away that it gives another demographic a chance. And then in the midst of all that, so we're breaking ground on this condo. It's going to take about a year to build. And one of our endo buddies had a friend that had just opened up a place in Harker Heights. And we're like, Harker Heights? That's like so far away.
We didn't even know where it was.
Yeah, I mean, I honestly had to look it
heard
up
of it.
on Google Maps or... He's like, well, why don't you guys just go up and meet him? You know, he's up there and he's got space and it's not gonna hurt. So John and I get in his car at the time and we drive up and we meet him and we're looking and it's like 2 chairs and maybe a third chair. We're like, well, you know what? Let's try it. So all of a sudden we went from 2 to 4 offices in a span of like a year and a half. Yeah.
And it was just you two at that time, right?
Yeah, and that was a crazy time. I think we drove the staff nuts because we were both working at all 4 locations. And so it was a huge scheduling rotation. Yeah. And that's when we started heavily considering the idea of an associate, but we had never had, you know, it'd always just been me and John kind of like spitballing ideas and you know, we called it like sweat equity. We're just gonna keep going and keep doing it. We weren't making necessarily any, you know, any business out of it. We were just doing what we thought was good. So it was kind of, hey, we're gonna go in and do perio and dental implants and we'll figure it out on the back end. Yeah. And it just grew and we're like, okay, we need somebody to help us out because I don't think we can keep going like this.
At the time when you had 2 offices, how many staff did you have?
It was pretty small, like
Yeah.
I want to
I
say
think we have 1 hygienist.
Like 2 assistants each kind of thing?
Yeah. And 2 office managers. I don't know.
yeah, like
About a third of what we have now.
Yeah, I know. Now we have what, like 30 people on our staff?
probably maybe more.
Maybe more.
Yeah, at the time, like maybe each office had 3 people, you know, 3 staff members, and then we shared a hygienist, so 4 at a time. I mean, it seems so crazy that it was so small, and there was a lot of just figuring it out. You know, like if John had a sick assistant, my schedule was lighter. It was like, okay, can you go help, you know, John out in Georgetown because. And we still do that, but it was very much like, hey, do you have a busy day or can I borrow an assistant like halfway through because, you know, somebody needs to go home and it's like, okay, we'll figure it out, you know?
Yeah.
Which made us, I think, a little bit more resilient too, to not freaking out over the little stuff. But, and then training too, because perio is so different than general dentistry. So even if we had 2 assistants, a lot of times if one of them was newer, it's just like, how do we train you to do surgical procedures where you're used to composites and crowns and things like that? So we did a lot of back and forth with assistants, so they would get different kind of ideas, work with John for a little bit, work with me for a little bit, flip-flop, you know, see who fits personality-wise. It was very much like, we'll work together to get this.
Well, that's good for the assistant, right? Because then that way they're able to kind of fit with the right person instead of just being dropped into a, you know, in a situation where they may not be comfortable.
Yeah, and I think it also, the biggest change that came about when we started having associates was the fact that John and I kind of trained similarly in the same time frame. And then when we started interviewing and seeing associates, it was, you know, during the shift of, wow, we have all this technology. Like, you know, you talked about computer science and all that stuff. Like, we didn't, you know, John and I took film x-rays and our
Tomograms.
Yeah. I mean, the biggest thing when I was in perio residency was that we had PowerPoint and not slide decks. And there were still old slide decks. We still had...
I had some too. I had some professors who just had those little, what I know what
they'd
they're
come
called.
in with their carousels and put them in, and we're watching it and converting them to PowerPoints. And even small stuff like our journal articles were all paper, right? So we would go grab the journals, go to Kinko's and photocopy them for the other residents.
That's
and-
funny. That's
Yeah, by the end of our 3 years, I had like 4 cabinets.
Yeah, just filled with
Filled
paper, you know.
with paper.
I still have my journal
You kept
articles.
them?
I just feel like
I
it's
kept
so
them
much
for a
paper
while,
that I don't want
But
to
after
just.
moving once or twice,
Yeah.
it had to go. It was like,
I kind of condensed it, but it's still there.
I think that when you have them in paper, you're more apt to really understand them more and read them and understand them more.
It was, yeah.
you can highlight and make
You can
notes.
highlight and make notes. Like, you know, I grew up in the PDF era.
Yeah.
And so everything was
Yeah.
PDF. And I printed them most of the time whenever I could. But whenever I printed them, I would learn them more.
Yeah,
So,
that's a good point.
yeah.
Well, it's funny because one of my co-residents came and spoke recently in Austin. We were reminiscing about going to a coffee shop and your like backpack is this big with just papers, you know?
Yeah.
And I'm sure the people at the coffee shop are like, what are these guys doing? You know, stacks of journal articles and they're just there for hours drinking coffee. Because we were, you know, poor residents. I mean, we would find like the cheapest, you know, coffee place and free Wi-Fi and buy like one food item every couple hours just so we could stay there. But just, you know, I look back at those folders and I'm like, oh my God, the amount of time I spent just sitting there reading journal articles and highlighting them. And if the photocopy was bad, you know, you're cursing the resident who was in charge of photocopying, like, why didn't you do a better job with that, you know? And it's just funny to think that now this is all available. Yeah, I could pull my phone out and search on PubMed. And
Right.
Yeah, all those articles I have on my phone still to this day. I
Yeah.
have on my Dropbox app and I have them all saved.
That's just,
So
it's
it's nice.
kind of crazy.
Yeah.
It's kind of like music where you have streaming versus prior to that, you
Yeah.
had the physical copy.
Yeah. Like
Right?
your
You
old
felt more
CD
invested.
case and your, you know.
You're more invested.
Yeah.
Yeah, that was interesting and little things too. Like I think it's super cool that you had all that technology, right? You had digital X-rays and all that stuff. But I still remember times like going into the dark room and developing the X-rays.
Yeah, I've never had to do that. So I have
And
no
then
idea.
like somebody opens the door accidentally and all your X-rays are exposed to light and you're just like, oh.
Or
how
how
did
about
you-"
if you're doing an implant
Yeah.
and you take your pilot drill, PA, you go feed it in, you wait
Yep.
30 minutes in line, and then you come back and it's cone cut.
Yeah. And you're like, oh, I
And
gotta
you're like,
wait.
I gotta go
you know.
retake
God.
it and then wait in line for 30 minutes. An implant could take you 6 hours.
I couldn't imagine.
Yeah.
That's
Or
crazy.
did you ever have to quick dip when you were in school? Do you know what that is?
No.
So with film X-rays, if you wanted, like,
It's
if
like
you-
the phosphor plates?
no, these are true film
Oh.
film X-rays, and so you would have this little box in a dark room, and you'd put your hands through there, and you'd open up the X-rays, and there were 3 little containers: developer, fixer, and wash. And so it's kind of like photography, you know, like old school
Yeah.
photography. And you're dipping him, you know.
Yeah.
So, but you're in a rush, right? Because you want to see
Yeah.
the X-ray to make sure that your depth is correct and everything.
That's right. It was like the quick route, but the quality was not as good.
Not
You
as
didn't
good, but
run it
and
through
then
the
your hands
machine.
smell like developer, and you know.
Yeah, because the X-ray machine would take what, like 5 minutes to go
At
through
least,
it,
yeah.
just to wait to see if your pilot drill didn't have a cone cut. It was
Yeah.
a nightmare.
Well,
So, and I know it's made a big difference for endo as well.
Oh yeah, I'm sure.
Oh,
But
yeah.
just the thought of taking like a full set of X-rays, you know, because
that probably took hours.
it took a
mean, like-
consult took a long time
Yeah.
because we, as at least in our residency, and I think most perio residencies are the same, we take a full complete set, right?
Right.
So we're talking about
20 X-rays.
20 X-rays and developing them
And manually putting them in.
and manually feeding
Yeah.
them, and you know we took the duplicate ones, so we had 2 films in each packet.
Okay.
So we want, and you know, and then you're putting it up on the light box.
Uh-huh.
And the way our residency was set up was the older residents would kind of check your X-ray quality,
Oh, okay.
and then the faculty would come in and check it. And so you put it on this light box, and you have all these X-rays that you just spent 30 minutes, taking and then developing. And they're just going through and they're like, no, this isn't good enough. No, this isn't good enough. No, this is good enough. And maybe there's like 5 left at the end. They're like, all right, go retake them, so you can see every structure the right way.
Yeah.
So it was good in a way because it makes you, at the time, you're just like frustrated, right?
Right.
You're like, oh, why?
But it's good training for taking
It's good
X-rays.
training, but it's funny because now it's like, if the X-ray doesn't pop up in 2 seconds, you're like, oh,
Like,
what's
we're
taking
frustrated.
so
Let's
long,
say-
The sensor's broke.
Yeah.
Yeah, is the sensor broken? Is the
Call
connection
Shamika.
not in there? Yeah,
Shamika.
call IT, get them in here, and even just the quality of like
Yeah.
what we can see now versus.
Remember, even when digital first came out, there was a developing box, right?
Yeah.
Remember that?
Yeah. So is the phosphor plates and
Yeah.
stuff like
Okay.
that, and you'd have to put them in this machine. It's still developed kind of like.
But it was still time consuming.
It was still
That was the first step between traditional to what we have today.
And then even the sensors, the first sensors were so large. Like they had this huge thing, and then you had to work on the. So you had to kind of know a little bit of tech stuff and figure it out because, you were on your own.
Even
but-
still, because you have the USBs and if there's
Yeah.
no driver. The driver is old. It's not going to
Yeah.
work, and it's just such a pain.
I think what is a periodontist is can be very narrowly defined, but it really has evolved over the last few years. And, I was talking to Sham about this earlier, but when John and I went to school, perio was very much at that time focused on not just the treatment of periodontal disease and placing implants, but the techniques at that time. We were heavily focused, and we still are very focused on regeneration. Part of being a periodontist is treating the results of periodontal disease, which is oftentimes bone loss, tissue loss, and for us, we consider tissue loss as hard and soft tissue, right? So gum tissue, bone, right? And dealing with those effects. And a lot of our training involved repair of those defects in the bone, because our goal ultimately is to try and retain your natural teeth for as long as possible. That's really what it is. And periodontal disease is an extremely old, if not one of the oldest kind of known about diseases, even from Egyptian times to Greek. There's stories of these ancient scholars like realizing that there's a link between the accumulation of plaque and tartar and deposits on the teeth and what happens, and it's an immune response. And so periodontics came about as a specialty in, I think, 1914, around that time, because we started to see this distinct disease phenomenon of periodontal disease and requiring a specialty training on how to manage it. Because technically periodontal disease can affect everybody, we know that, but in reality there's a genetic subset of the population that is more prone to it. And so in the beginning it was treating the results of it, right? And as we went through residency, as we came out, then the focus started shifting on, well, now there's a systemic link to it as well, right? We were finding out about low preterm weight babies. We were finding out about cardiovascular risk, the link to diabetes, smoking.
Now they're finding links to Alzheimer's disease as well.
Yeah, Alzheimer's. Even during COVID, they were finding links. So it shifted from the treating the results of it and to more of how can we
Prevent
and holistically treat, other things.
Right.
Because I'm sure you've seen this with some of your cases, but as a patient who maybe has had a long time apart from regular dental care, starts periodontal treatment and starts going through it, they start also taking kind of a deeper look at their whole health, right? And a lot of times that's at our urging, right? They come in and they might have diabetes and hypertension, their blood pressure's through the roof. We ask them, hey, what was your last A1C? And they're like, I have no idea, right? Well, we want to know that because we're finding out more and more links. Your A1C is above 7, there's probably going to be more periodontal breakdown because your immune response is in.
Right.
So I think the goal of a periodontist is to preserve and maintain your teeth, treat the periodontal disease, but now it's evolved to, all right, we're looking at the big picture, right? Mm-hmm. And then implants came into that as a way to fix missing teeth or replace soon to be missing teeth, because a lot of previous periodontal therapy was, let's save these teeth at all costs, because there wasn't a viable alternative. The only alternative was either looking at partial dentures or dentures. And so now I think it's more taking an analytical look at, all right, well, what is the short-term prognosis of this tooth? Can we keep it for maybe the next 5 years while we figure out a long-term game plan, which may include dental implants, which now may include orthodontic therapy or prosthetic therapy. So I think we've shifted from reactive to more prevention, and also treating this whole complex of, all right, well, if you're missing teeth or if you're going to be missing teeth, how do we efficiently replace that with a dental implant, and what does that involve? Before, I think people were just, okay, we need to retain a tooth. That's what an implant was. Now it's more, okay, let's look at the tissue. What can we do to maintain this implant long term? Because I don't know about both of you, but I feel like now we're in this, we're not just treating periodontal disease, but now we're treating periimplantitis and the complications that come from implant placement. Like any device that's implanted in the body, you're going to have a subset of the population that's going to have complications with that. Right. And I think that's where our treatment has gone. And at least that's kind of my main focus. I know you like a lot of the soft tissue aspect, and you can probably talk more about that, but periodontal gum grafting or cosmetic contouring, which I also enjoy too, but I think the younger and newer periodontists are very much focused into aesthetic gingival grafting.
But going back to just periodontal disease in general and people losing teeth, people are living longer.
Yeah,
now,
that's true too.
Right? And so with people living longer, they want to enjoy their time, enjoy being able to chew, and dentures and partial dentures, they work, but not for everybody. And so they want to have a good quality of life. And so with that quality of life, they want to have teeth that stay in the mouth. And so implants have been able to do that for people for the last 50 years or so.
Yeah.
But going back to what you were saying, Rishan, about soft tissue, stress has been a big part of the last, always, but people are more stressed these days. There's more grinding of teeth. There's more aggressive brushing because everyone wants to look pretty and wants to eat bright white smiles. But what's happening is that people are losing gum tissue from all this. And when the gum tissue gets lost, the teeth eventually will get lost too. So the idea is that if we can restore that and rebuild that gum tissue for people who are having improper habits, we can rebuild and help them save their teeth for a long time.
Do you think that, I feel like people don't realize how important the function of that gum tissue is. Like we see it every day, but for even a tooth-borne restoration, like a crown, right? Like, I'm sure you see it all the time. Somebody who has thick, healthy gum tissue, no issues around that crown. Like no problem keeping it clean, nothing. But when they have that thin gum profile, it's always red, irritated, and it's not for a lack of them trying to keep it clean, but...
No, part of it's genetic too, right? I mean, they're just genetically, they have thinner gum tissue, and so those are the cases where they have to be really diligent about keeping them clean. And if they're not clean, there's bacteria piling up around the gum line, then this is going to cause the gum to get inflamed. Bacteria is going to retain their plaque buildup. Eventually, there's going to be a cavity underneath the crown, or gum disease will form, recession will happen. And so those are situations where if the gum is thin, it's always irritated, it might be a good idea to maybe have that checked to, get a graft done.
Yeah. And then John, I don't know about you, but with adult orthodontics, like when we first were were practicing, I don't think we saw as many adult ortho patients as we do now. And I think now they require, you know, because we're changing
And
things.
people you may ask, why does that matter for a periodontist? Because orthodontics can be a somewhat risky procedure when you're removing teeth through bone, and in the presence of any type of periodontal disease,
Yeah.
it could be catastrophic. So we do a lot more. You're right. In the last 10 years,
Because like with kids, you don't, unless it's an early onset or
Yeah, that's so
aggressive
rare.
perio, it's so
Yeah.
rare, right? But now with adults who are having ortho at different time points, the risk of having a periodontal condition or disease is so much
Yeah.
higher, right? So it's like this shift where I feel like we used to work with orthodontists only mainly for
kids,
like
tissue
cranectomies or
grafting.
Premolar
tissue
extractions.
right, like that type of stuff. And then now it's shifted to, well, I'm considering doing orthodontics.
Yeah.
You know, what do I need to do to make it so
Right, they may
that
say this patient has recession, or this patient has some bone loss.
right,
Is it okay to move forward?
right. Or even the other thing now too is, where does the timing or placement of dental implants come in? Because some of them are missing teeth as well,
Right.
right?
That's a big aspect. Almost in most cases they are.
Yeah,
And
and
they're uprighting molars and things like that. So it becomes a really kind of interspecialty type. Getting creative with trying to figure out the timing of the implants. Do you graft before you move the teeth as far as recession? Do you graft after? There's a lot of different decisions to make when it comes to adults. So that's been a pretty big change in our specialty probably in the last probably 10 years.
yeah, I think that's one of the biggest changes. And I don't know if you're seeing it as much up here, because one of the things I think that is going back to, you know, how CTP formed is each area that we practice in has a little different culture. You know, the population's a little bit different, so their needs are a little bit
Oh,
different.
trust me, I know.
I'm sure, yeah, you know, you go to all of them.
I see it
so-
every day.
but I feel like this social media focus on faces, and unfortunately a lot of people getting what they think is like an aesthetic long-term restoration, whether it's veneers or things like that, but not taking into account the periodontal structures around there. I'm seeing a lot more aesthetic crown lengthening or functional crown lengthening at this point, because maybe they had a full set of veneers done 10 years ago and they need to be replaced, right? Well, there's not as much tooth structure remaining, right? Or they had it done and they're unhappy with where the gingival margin settled, and so now it's going back in and doing more aesthetic crown lengthening to kind of make it look the way we want it to, or they want it to.
Yeah.
It can be sometimes difficult to describe exactly what we do. I mean, I don't even think my kids know what I do at the time. I'm not kidding. But if I was describing it to just like a new friend of mine I met, I'd kind of describe it as we're kind of the specialists when it comes to your bone and your gums, your gingiva. And, you know, we're also, you know, highly specialized in implant dentistry in the surgical aspect, and, you know, full mouth type rehab cases. That's kind of how I describe it, you know, if I'm talking to someone who's not in the dental field. I mean, is that kind of what you guys?
Yeah, because it's very hard. There's
It's
so
hard to
many
describe.
procedures we do
Yeah.
that it's hard to just say, oh yeah, that's, you know.
Yeah, but
Because if you just say gum specialist, they still might not understand.
right,
Right.
because historically, periodontists, especially before implants started becoming a thing, truly were strictly like old school perio osseous, right? There wasn't implants. Most of the time, they didn't do many extractions back then.
Yeah.
The field is
Well, they were trying to avoid it, I
right,
think. you know.
exactly. But the field has expanded so much that, I mean, to try to define what a periodontist is difficult, but it's also exciting because we encompass everything. But I feel a lot of times we're almost like, in a lot of ways, like the physician of the mouth.
Yeah.
Almost
Well,
like a
there is
super dentist type of thing. Not super dentist per se, but
because there's so many oral disorders that happen that are not related to necessarily teeth disorders that we diagnose. We do a lot of soft tissue biopsies, and we diagnose all kinds of disorders and things like that. They're not necessarily related to a tooth issue or traditional perio disease. And then we treat those with either systemic medications or even topicals. So we do a lot of what we call oral medicine as well.
Yeah, I think oral pathology was such a lot of the original periodontists came from that oral
Yeah.
pathology type of oral medicine.
Yeah,
type
we're kind of, I guess you would say the periodontist is kind of your go-to specialty for anything that would be unusual. Like if you stuck your tongue out and you saw something on it, or you looked at your lip and you called your general dentist and they said, who should I go see? They'd probably say go to a periodontist because the soft tissue is our realm, so to speak.
And I think we differ and share certain things with oral surgeons, right? You know, we're both,
Yeah, there's a lot of
we
crossover.
both have surgical specialties, but we're more narrowly focused on
The soft tissue
soft
is
tissue kind of,
always our priority, right?
and they're more, you know, I say it's more like micro and macro.
Yeah.
you know?
Right.
They're looking at big structure changes. You know, do they need to fixate a plate? Do they need to do something involving the entire bone? Whereas we're focused on
that specific area.
that specific area, or you know, certain problems, right, that need more of a prosthetic standpoint, you know, where okay, the big picture stuff is already okay or settled, you know, like let's focus on how do we make this fit the prosthetic side of it. And you know, that's what makes it fun too, because we can do so many different things. Like if you like a certain thing, you can narrow your focus there, but we're also not doing things outside of our wheelhouse. You know, our focus is here and everything encompassed with that.
Right.
And that's where all our journal articles, you know, are focused on. And it's a lot. I mean, I'm sure you remember all the nights of reading tons and tons of journal articles, but the focus is always how do we make this better? You know, I think most periodontists look at a problem and they're like, I want to make this as close to perfect as I can, you know,
and natural.
and natural. I think if we go back in time, like when the ADA, the American Dental Association, realized the importance of specialties, it's because the idea, at least originally, was that your general dentist was the place that the family came to, you know, for your general needs, right? You needed cleanings, you had fillings, you had maybe a crown that you needed, and that in it of itself is a lot of stuff for a dentist to deal with on a day-to-day basis, right? Because the concept of a general dentist is you're treating everything in general, right? So that's a lot of different things coming at you. So the idea came from, well, this person needs a root canal as well, and an easier root canal, sure, I can do in my office, but for a general dentist, that might take them longer than it takes to do a filling or a crown. So I'm going to refer that to somebody that their scope of practice is narrowly focused on that, right? Or, for instance, I've done the initial treatment for periodontal disease, which is often scaling and root planing, which is deep cleaning. You know, we're going to numb you up and get the deposits off, but that can only fix so much, right? And for a general dentist to now try to treat the advanced part of that would take either a lot of time spent in continuing education or time spent in the office that they don't have, right? So the idea is, okay, this is beyond what I want to do in my office and what I can do, so I'm going to refer that out to somebody who only focuses on that. So it's taking, you know, the focus and defining it. Now, what's changed is, I think with technology and all the things is, I feel like general dentists have to do a lot more than just that now. You know, a lot of them need to be trained in at least, some form of orthodontics or identifying orthodontic changes. They need to know about all the different new materials that come out. They have to be aware of trends. There's a lot of patients that are doing travel medicine or travel dentistry, and they're getting stuff done in other countries that necessarily don't work or don't fit the lifestyle
or last very long,
right?
Unfortunately.
So I feel like their breadth of what they need to know and their knowledge is so vast that, if anything, it's even more important that there's specialists around, because it's just hard to keep up with everything. So I feel like they're the first line of triaging what a patient needs. And then they're gonna serve to, okay, this part we can do here, this part you should see a specialist for. But we're gonna try and work together to get it all done. And that's kind of the way it historically has worked. I think what's changing is, because patients, we live in a global world more than ever now. They're moving around a lot. They're coming from different areas. So now they're seeking out, there's more specialist problems, So now we're not dealing with this generalized periodontal disease. We're dealing with problem-focused areas. I had my implants done 10 years ago, and in this past 10 years, technology's improved, and I've always had this concern, how do I fix it? Or what can I do to fix it to achieve the goal that I want? And I think that's the big difference that we're seeing now, because we're not doing orthodontic treatment. We're not doing fillings. Maybe here and there we might do some, like an implant crown for a patient for a special case, or a temporary crown, but it's very much still, that's the realm of what a general dentist can do, and they can do better, and they see that material every day. And same thing for us, we see implants every day. So if I'm gonna place a dental implant, I'm looking at where the tooth's gonna be, but also, well, this bone is 6 millimeters wide. I can place a 3 millimeter implant in there, but functionally, is that good for the site? And if it's not, maybe I'm gonna augment the bone. And maybe that skill set is something that would take a long time in a general office.
Periodontal disease is a bacterial infection of the mouth, of the gums, and of the bone. It's a accumulation of plaque, causes bacteria to attach to it in the mouth, and over time, if it's not maintained and cleaned properly, then the soft tissue starts to break down and the bone starts to break down. It can start as a reversible process of gingivitis, and then as that gingivitis stays there for a long time, the bacteria starts to break down the bone. The bone breaks down over time, and this is something that's very important to be caught early. The earlier it's caught, the earlier it can be treated by non-surgical methods, from scaling root planing, like Rishan was saying, from deep cleaning. Deep cleaning is meant to remove the deep deposits underneath the gum that you can't get from brushing your teeth. And over time, after that's done, the gum tissue gets healthier, the inflammation goes away, and if it's early enough, then the bone loss usually stops there, and if it's maintained for regular cleanings every 3 or 4 months, the patient will stay healthy. Now, when that gets unchecked or not caught, because patients either not going to the dentist or they're not taking care of their teeth, then this progresses and bone loss occurs and continues to occur until the teeth have serious issues, they become loose, and then they have to be extracted. And so it's really important to have that kind of follow-up with a dentist, and to go to the dentist and, of course, brush your teeth and floss your teeth to maintain that so it doesn't occur.